Welcome to the show, Dr. Esteves. Great to have you.
Thank you.
Now, most people think that pain is in the muscles and joints. I mean, especially most chiropractors, osteopaths, medical doctors, all healthcare, massage therapists, down the line physical therapists. But Dr. Jorge Esteves, you seem to think something very different that's really got some merit to it, and that's how our lives, the pain is in our predictions, and that the right mix of touch, movement, meaning can rewrite those predictions. So we think of low back pain as being one of the worst conditions in not only this country, but in the world, probably because we're so much more sedentary than ever before. And, the cost and disability is so high. So could you please explain how the brain and how the brain's story provides that pain? And
First
what
off,
that
welcome
means?
from Portugal.
Oh,
We're talking
that's
to a man
right.
from Portugal right now, so that's
Yeah.
pretty cool.
Thank you.
Yeah.
Okay, so let's start this. I think starting from what a lot of chiropractors and osteopaths still sort of think these days in terms of their approach to things such as low back pain. They tend to be very much based on muscle joints and the kind of dysfunctions or subluxations, using chiropractic terminology, or somatic dysfunctions if we use an osteopathic terminology. And I think there's still amongst a lot of practitioners an idea that fixing that dysfunction, fixing the dysfunctional body, is going to be sufficient to restore health and to restore patients to the sort of to where they were before, to a sort of a healthy life and a happy life and so on. And I think that can be true, I guess, in situations where things can be quite simple, quite straightforward, quite linear. Someone did something, kind of twinged a little bit, feels a little bit of the pain, goes and sees a practitioner. Practitioner reassures and does a manual intervention, and the patient feels so much better. And whatever happens, there's a sort of a lot of times I believe that was a cause and effect. I had this, I went to see that practitioner diagnosed me with that particular problem, and did some sort of intervention. I feel so much better. So therefore, there's a sort of a causality there, kind of me with back pain, acute back pain, going to see the practitioner, I get so much better. Surely that was based on, on the intervention. And that's true in a lot of cases, those kind of straightforward cases, even if you're thinking about, okay, that's the natural history of the condition, patient will get better anyway, but it is a sort of something happens. I think the challenge becomes when the patient has got persistent pain, has been the pain has been there for quite a while. They have tried different approaches. They went to see the doctor kind of prescribed some kind of medication, got him to do, or her to do some diagnostic testing, kind of MRI scan and so on, shows, for example, a disc prolapse. And then I think that starts the story around the dysfunctional body, something that is not as before, something that needs to be fixed. And I think this is the message that we see in clinical practice on a daily basis. The sort of the failed intervention that someone started with the same sort of mechanical, simple back pain, but where is the patient number one went to see the practitioner, got so much better. Patient number two with exactly the same condition, for whatever baggage that patient brings to the table, history of life, previous experiences of pain, sort of going back to childhood, for example, and so on. All that story sort of builds to something that becomes very personal and very unique to that person. And in some cases explaining, okay, this is your problem, you've got this kind of disc prolapse, but there's nothing to be worried about. For some patients, that's reassuring. Okay, yeah, sure. You know, doc, I went to see my neurologist and he said nothing to worry about. I'm not a surgical patient. Go and see someone or do some exercises and get better. Others, oh, I've got this. I read something on the internet. I spoke to my friends. These days I can even go to ChatGPT and ask, what is that about? And I get a lot of input. Before we were talking about Dr. Google, I guess these days you can talk about Dr. AI in whatever form of AI. Yeah. But we're going to ask the questions, and the questions come. Sometimes a good question, a good answers. Other times, actually bring more anxiety and so on. So that patient, in some cases, starts this journey of trial and error, always with an idea that I need to fix something that is wrong with my body. Now, of course, being a person, being an organism first, but being a person, the whole concept, what is a person, what is personhood, is a complex construct, because it starts by having a body, and having a body is a fundamental part of the jigsaw. We use the body for many things, for sort of inputs from the pleasures in life, to use the body as agents to interact with the world, to do the things that matter to us, to sources of pleasure, and so on and so forth. So of course, that sort of body is a fundamental part of that, what do you call the self. So of course, when that, and I think it's important to consider that in a lot of times, when everything is functioning well, that body tends to be invisible, right? We do things, if I go to the gym and I'm sort of, I enjoy squatting or whatever, I'm squatting. I'm not thinking about my body squatting, right? I'm just sort of going with the sensations. I put more weight. I feel great about this. I go for a run. I like this stuff and so on. So I'm not focused on the inner sensations necessarily. I'm just using my body to do ultimately what I want to achieve, which is, I like exercising. I like lifting. I like running. I like doing, and then I like playing the piano. I'm not thinking about my fingers on the keyboard. I'm playing. I'm enjoying the music. So the body tends to be invisible in most of the things we do in life. Now, what the interesting thing, and I think that's where probably is a good question for practitioners, what happens to the body when the body becomes dysfunctional? Okay, whatever that means. And what does one do with the body? If I've got back pain, then in a lot of times it's very difficult to ignore that back, my lower back. I can't ignore it. I tend to go there, I touch, I press, I squeeze. Yeah, still here, still sore. I put ice, I put heat, I do something, I rub something, I put tape, I go and see the chiropractor or the osteopath or whatever to fix my back. So the thing about, and I think this body that is invisible and is in the business of enabling us to be agents, very much sort of free to do what we want to do, then we sort of become trapped in that sort of body that became very visible, and it's kind of there most of the times. And I think, of course, that the natural kind of tendency for someone is to go and see someone that can fix that body, right? So the body is still here. I think it is still important, because that's ultimately, who we are, is also because we have a body. Okay. And, that body enables us to sort of navigate the world and be who we are ultimately. So I think if we're thinking about starting from this perspective, what these ideas bring to the table, it's the idea of, pain ultimately is an experience. Okay. And, as an experience is attached with, many things in our memories from previous examples, if previous episodes of the same sort of pain, or even worse type of pain, to the experiences of pain of our family members, of our friends, and so on. All that stuff, ultimately contributes. So here, I think it's also important to think about even culture and religion and so on. All those things contribute to the experience of pain. And some people being maybe more resilient, and that's okay. Pain is actually part of it's part of, it's part of a process anyway. In other societies, no, that's not, it's horrible to have that stuff and I need to get that fixed. So, and this leads to sort of at times acceptance of the problem of not. So I think, it starts from that experience, and that experience, brings those memories, those, what in Bayesian terms are called the priors, something that is in the database, basically. There's a memory there of something. And I think that sort of enables the system to predict probably what's going to happen as a result of that.
You have aroused my curiosity. I mean, here, let me lay the groundwork. I mean, you are an osteopath. You graduated from the International College of Osteopathic Medicine in Malta. You're trained in a certain manner that is traditional to your practice. As chiropractors, we are trained in a certain way. How did you come up with this? Because I imagine that wasn't part of. In fact, back in the day, psychosomatic pain was almost an insult to people. They thought, no, it's not in my mind. It's not. I'm not imagining this. So, how did that all start for you?
When I graduated in the 1990s and start, of course the training was very mechanical.
Yeah.
Like most of us had, either osteos or chiropractors or even physiotherapists, we had a very mechanically based type of training because, it was the idea that is the body and you fix the body and ultimately you the guy in charge and you tell the patient what is best for the patient. You're going to have these sort of miracle fingers, your palpation skills are so good that you can diagnose anything that moves or doesn't move or exists or doesn't exist, jokes aside, but that's it. So, you go there until you start, I think, being stuck on cases where you think, either for me it was like the observing that there were patients that got so much better and you think, but what did I do? Why did that patient that tells me, oh gosh, I'm 95% better. And, I saw the guy a couple of days ago and I think, why? I didn't do anything actually, or maybe the guy was too acute. I suggested, maybe sort of, put some ice and do this stuff. And I'm going to do just a simple intervention here, just a kind of unlock things, whatever that means. And then the guy comes back and says, so much better, and think, okay, that's an interesting phenomena here. Clearly it was not just a mechanical thing. Okay. Down to the guys with persistent pain that, whatever you did with the mechanical models, things did not sort of seem to have changed that much. And I was in the early days, I was heavily influenced by what was around, not just necessarily in osteopathy, but also I know also in chiropractic. I think people look sort of the work of Vladimir Janda, the muscle sort of imbalances, and all that stuff. Sort of remember, consuming a lot of the work of Craig Libenson, for example. So for me, it's a sort of an osteopath looking into chiropractic kind of textbooks was a little bit like, something, you shouldn't be doing. But, I was very interested very much in the sort of, learning. I didn't feel like, my profession is just this. I considered, the importance of looking outside and bring to the profession things that can contribute to the development of the profession rather than being stuck in the sort of principles and things that from the late 19th century and, where people said this like this and has to be like this for the rest of, of our lives. No, I started challenging it. And that sort of led me into, research and, when I did my PhD in cognitive science, I was very much interested in the phenomenon of palpation and try to understand what that was about. And I had the opportunity, I had great supervisors that were from the field of neuroscience, nothing to do with the profession, because, I remember them saying, well, you already know about the profession. So, if you want to find a supervisor within your profession, that's fine. But, but for me, no, that's okay. I'm interested in understanding the other side and how can I bring this to my field and try to sort of shape things around this. And that sort of led me to, with our patient interest, to the effect of touch and exploring the effect of affective touch. And we did some research with preterm babies, trying to understand actually what happens when you touch someone. And the preterm baby was a good model because arguably did not have many expectations. A baby that is 34 weeks old, how much touch does it have of experience? Arguably some, if the mom kind of touched from the outside during pregnancy. Of course, if they're twins, they touched each other. But otherwise, that was the model. This is a good opportunity to see actually what is the effect of touching someone on the physiology. And we observed, interesting findings of sort of, autonomic arousal as a result of very gentle touch. For example, oxygen saturation going up and so how come, or heart rate variability changing considerably and so on. So it's sort of very interesting things to observe, and that's where the journey started. And through that comes the whole kind of world of multisensory integration, Bayesian brain, and then the links to pain. And so that's why. So the kind of trying to understand what we do from a different perspective.
How would you approach a patient now that comes in with even low back pain? I mean, our listeners and viewers, obviously, the majority of them have some sort of low back or neck pain. But what makes your management that much different than the way you were trained?
I give a lot more attention to understanding the narrative of the patient. So a much bigger emphasis on the story that the patient brings, rather than jumping straight into kind of diagnostic questioning. Where is the pain? Where makes it worse, and so on? How long did it start? How long ago was that, and so on? Of course, that is if we put in a kind of using a Socrates model for case history taking, and you ask a patient that has just had an episode of back pain is acute, of course that makes perfect sense, because also we need to be safe and we need to make sure we're not missing red flags and so on. But I think if you have someone with a long history of back pain that seems to have seen quite a lot of people, I think a fundamental part of that jigsaw is to understand their story. It's sort of what is their story. And I think in their story, of course, comes the more diagnostic things that we should still consider, because we need to be first and foremost safe. Ultimately, we operate as primary contact practitioners, and we need to understand, okay, this is something I can do, and this is something needs to be referred to another clinician to sort of additional diagnostic testing and so on. So I think an emphasis on the story and sort of understanding the story brings to the table a lot of the anxieties, a lot of the frustrations, the bouts of depression, the things that the patients may say they used to be able to and no longer able to do, to what matters to them. Because the thing, again, if you end up sort of prescribing, for example, some form of exercise to the patient, but a patient tells me, I hate exercise, that's not the thing that really matters, and you did not listen to the patient, you're going to sort of, sell them a few exercises, go home and come back next week. Whereas if the patient says, what really matters to me is to be able to get back to the bike, or to go back to the road, or go back to the gym. Yeah. And I think, okay, fine. If you understand that you are, you arguably have already an action plan. You have a treatment plan that you started developing together with your patient. So that's the sort of one we're talking about, person-centered care. And I think, it's a very sexy thing these days, but a lot of people that arguably say they do person-centered care, they end up doing practitioner-centered care, because they decide what's good for the patient. And I think a lot of times, the patient are telling you really what matters to them, what is the fundamental thing in their lives. If we treat an older person, what matters to that person is probably just basic activities of daily living, perhaps, right? be able to go out and see friends, go out, shopping and so on. And with that comes the social part of it. Because again, what we observed is a sort of, for example, the changes in a very mechanical model we had before to a biopsychosocial model became this thing about, we divided things we have compartments. It's bio or psycho or social, and we say, yeah, we don't do the psychosocial really. But if you understand the patient's story and really, arguably psychosocial is biological as well, because if you don't feel well in yourself and you don't see anybody and you kind of you're stuck at home and so on, your biology changes, right? You're depressed, inflammation is up, and and so on and so forth. Your immune system is sort of fighting. So I think understanding the story understands us to sort of to see, okay, right, what is the next stage? Is probably to improve something in terms of maybe it's the quality of movement, maybe it's reducing the symptoms, so the person can start feeling some change and be able to say, well, it's getting better. For example, I understand the process. Because I think listeners would probably have a lot of experiences similar to this one, which is the patient comes to see you with a lot of pain, chronic pain, but he says, out of 10, how much is your pain? Well, it's 7 or 8. Right. Okay, gosh, it's a lot. Yeah, it's horrible. I suffer a lot with my pain. And the patient comes back, let's say after 2 or 3 sessions down the road, maybe a couple of weeks, and you ask the patient, how do you feel? Much better. Okay, how's your pain? Well, it's 7. And I think, statistically, you didn't change anything, right?
Yeah.
It's exactly the same thing. So the question there, what changed really that the patient tells you, I'm much better? Okay, so I think this is clearly not just a sort of physical, mechanical thing that changed. Probably that also changed, and that's also important, because I think what is also important not to take away is, I think, if we're going to start saying, well, everything is in the brain, which moves from a body-based kind of mechanical model to a brain-based model, which is still body-based, right? Yeah. So nothing changed. It's still biomedical because it's still focused on one thing. But, it's a sort of understand that actually through the body, the body provides us an opportunity of input to enable some changes to start occurring, right? Because it's part of who we are.
So interesting, because if we are good listeners, kind of like a psychologist or a therapist, and we utilize that background to guide the patient by, helping them achieve what specifically they want, but we're not psychologists, but we really cater to the thought process. So how do you explain to a patient, because what we do is so physical based on, traditional treatment. Oftentimes I tell my interns, I go, man, sometimes we play therapist. In fact, almost every time, but we're not licensed in that. So how do you justify some of that conversation to your colleagues, peers, students?
I think that's, first is one of the anxieties in the professions. I don't think is just mine when we start talking about these models and people say, well, I'm not a clinical psychologist and I don't want to be one. Okay. So I think that's the first point. We're not clinical psychologists. We don't need to be clinical psychologists, but I think, we need to have some of the skills that clinical psychologists have. And this is, it's a debate that's going on in the musculoskeletal world, let's say, because, can put here the kind of, chiros, osteos, and physios together. But it's clearly a debate going on about, communication being kind of soft skills or fundamental skills, for example. And I think, they are fundamental skills because, if we want to provide good person-centered care, then we need to be good listeners, we need to be empathic, and we need to sort of really, at times, help deconstructing some of the kind of, some of the rigid belief systems that the patient have, but not in the same way a psychologist would do, because we're not licensed to do that, but with techniques that using a lot of times is using the body, for example, or using words if you so wish. But the body provides, I think, the beauty of this, and actually if we don't lose the body, because the danger is, a few years ago when pain science became quite important, there was a lot of shift towards pain neuroscience education, and there were a lot of practitioners just kind of teaching the patient a lot about, this is your brain, this is how your brain works, no brain, no pain, all that stuff. To the sort of the point that sometimes, people would sort of, after 10 minutes of explaining to a patient what is a brain, what is a nervous system, and so on, that we felt like I've just lost the patient. Hasn't got a clue what I'm talking about. Yeah. Because the patient does not have a degree in neuroscience, yeah. And it's just too much. It's just it's a bridge too far. It doesn't change. It didn't change anything. It was like people then sort of, in a nutshell, then was, okay, what did you learn? You're telling me that the problem is in my head, right? Isn't it? So that was the shift from the problem is not in your body to the problem be in your head. So I think that was a danger. And then the sort of, again, one thing that tends to worry a lot of practitioners, at least in my profession, is that this idea that we're going to become just hands-off. We don't touch the patients anymore. It's just talking therapy. But the patients go to see someone for, the physical manipulative work as well, okay? And of course, you may decide on, at times that, there's less hands-on and more hands-off, and other times there's not a lot of talk and a lot of action, let's say. But I think the body provides that important anchor for the change. And I think that's what I think it's important to emphasize. Out of all this sort of predictive system that the nervous system is, the body is arguably the sensory landscape. And if you want to use an analogy, we become landscape gardeners, where we sort of really the input and the things we do can be through very specific type of manipulative work, but can be through very generic type of work, which is more akin to graded exposure therapy. If someone is very, is frightened of moving forward because the low back pain is horrible and forward flexion is what they really hate. If you somehow through movement and some, touch-based things and, you start changing the model, because they start thinking, oh, okay, actually I can, it feels better, I can touch my toes and so on. You are changing the model. You're changing the kind of depth, what is called the generative model. So I think that is, so the techniques still make sense, but I think there's an opportunity to refocus the lens and not just thinking about the technique as something that fixes a particular dysfunction, to think about the technique as a tool to get into that system and the possibility of, leading to sort of bigger changes. So that's the way I see it, not just a sort of the manipulation does that thing mechanically, because, the evidence actually doesn't show that the mechanical part is really what really makes the difference. So,
on that topic, Doc, you're starting to touch on a little bit. We aren't clinical psychologists. We do touch people, and you argue about a well-timed touch is very important. And what does a smart touch look like to you in your practice?
That's an interesting question. What is the smart touch look to me? I think, for example, when we touch someone, sort of, from a therapeutic perspective, and we are, there's a sort of course, a conversation going on when we, let's say, deliver some form of technique and we get some kind of outcome, right? So, I tend to teach my students sort of, okay, when you delivering the technique, you are constantly assessing what the technique is doing, right? What ultimately the tissues are telling you. I think, what the tissues are telling you, I don't think is just necessarily at the tissue level, but sometimes at a higher level, the person, when you're delivering the technique and the person sort of, you feel like, yeah, there is a sort of something starts changing and starts changing radically, in a sense of, wow, this is kind of fascinating kind of thing. It seems to have eased off a lot of this tension. For example, here the patient is telling you, at times, again, the patient may be telling you that, what, that hurts but feels so good. Okay, again, there's an anticipation of relief of part of that. So that is giving you the opportunity to really, okay, let's stay here for a little bit. And staying there, you can also then synchronize with other senses and other things in that body. So for example, you may feel like the patient is too anxious about what's going on. Seems like the tissue level, something is happening, but you might sort of think, okay, if I change the conversation here, okay, and if I start talking about football, for example, and it's the, you the sort of support the same team and so on, and they kind of suddenly everything changes because the focus is no longer on what you do, but the conversation that gives you an opportunity. I carry on working whilst I'm chatting to my patient about football, for example. Or you think, okay, the patient is super anxious about what's going on there, and you think, okay, let's use some mindfulness-based techniques by simply, for example, let's think about, for example, either use breathing, for example, or you could even do some visualization. Imagine you close your eyes, imagine you're in sort of the place you love going on holidays, and you can observe what happens to the tissues, because sometimes the tension goes away. The patient, what felt really tight was also because there was a sort of a huge anxiety about what's happening, what are you doing, is this going to happen, help or not. On the contrary, there are times where I think, we palpate, we feel something, and that is a sort of a straight away an acute response, a super protective response about what's happening there. And I think that is a question. Again, you can modulate with things. Okay, why is this? What's going on? But also, and I think this is also an important part of, who we are as practitioners, because we're hands-on practitioners. Sometimes that is potentially opening a Pandora box about, previous histories in the life of that patient about, abuse and so on and so forth. So the touch is a form of language, is of course an intervention, is a super powerful part of our therapy, but also a form of communication at times where you feel like, here, I'm not a psychologist, but I can use some techniques that potentially enable me to potentiate the effect of that technique. For example, making something that felt really uncomfortable to something, let's go ahead and do that. Or other way around, where we have the ability to perceive things where either there's an anxiety about the symptoms, a sort of a fear of movement, for example, and, when you touch the patient and go, and before you touch, they already sort of saying that's hurting kind of thing. So maybe there's a sort of sensitization going on, and you have to be careful about that and so on. But I think that is, that's where touch plays an important role, that hands-on care. And sometimes the words alone do not give you that, because the patient may say, well, yeah, it hurts over there, but a kind of, having that experience, that dialogue with the patient is a fundamental part of the jigsaw, in my opinion.
I agree. Dr. Terry and I have been practicing for a long time. I'm going on my 40th year, and I have seen phenomenal things that didn't used to make sense, but then when you start explaining it to your interns or new associate doctors, you start to catch yourself talking about listening skills, and being socially adept in a manner that most doctors of that generation are just all about writing a prescription.
Sure.
And so many times when you look back, you see patients that defy all the laws of healing, but you did something different. You listened to them, you put your hands on them a certain way. It becomes I think you referred to it like as a therapeutic alliance. And
Hmm.
how does somebody create that therapeutic alliance with a patient? And then how does somebody, unknowingly, create, a miscommunication or well, you can see it in a patient if you're perceptive enough that they're not having a good experience with you in the beginning.
Hmm.
But do you have any suggestions that would help with that therapeutic alliance?
So the therapeutic alliance is something that is kind of these days very much accepted across a number of professions as being essential for good, so to effective care. And there's, there is good research demonstrates that, good therapeutic alliance leads to better outcomes. uh, I think straight away one thing it's important to understand that, we it's highly unlikely that we're going to develop, robust therapeutic alliance with every single patient comes through the door, because that's just kind of human nature and communication and so on and so forth. Okay. uh, how practitioners develop a good therapeutic alliance, I think, starts with that capacity to really listen and to sort of provide an environment that is welcoming, that where they feel safe, where you have addressed their expectations. For example, I think that's an important part of the, that needs to be pretty much discussed at the beginning. For a patient that comes to see you for the first time, and you have one particular type of practice, one particular approach, and the patient expects something completely different. But if you did not ask, okay, you don't know, right? When so I think that is important, when part of, okay, tell me your story, but also tell me what's what do you expect out of this, interaction and this, process.
Mm.
And I think, if they understand, if we then sort of start aligning our expectations with their expectations, and we understand what really matters to them, and we understand what we can or not do. So I think, we start sort of creating the beginning of a relationship that is trustworthy. So the patient knows that it's not just coming every week because just want to cash in, basically, but they understand there is a process there. I think, again, that is important part to consider. When you explain to your patient after, let's say, your initial evaluation, what you found and what you think the plan of care is and so on, it should be a sort of a frank discussion about, okay, this is the plan, what do you think? Negotiate that plan with the patient, not something that is a sort of put on them because, it's sort of, you think this is the right way of treating you, and therefore, they need to obey. No, it's the other way around, right? So they are kind of, they're experts in their body. They know what can also afford. They either, the whole thing makes sense to them or does not make any sense. So all those things are part of developing that important alliance. How can people develop those skills and, develop robust alliance? As I said, communication, but communication here is not just sort of verbal communication. Non-verbal communication is a critical part of it. Just good listening skills. Knowing what not to say anything and just listening to them. As a sort of not to interrupt them all the time when you're asking the same question 10 times and they're fed up because they already answer you that stuff. Okay, when again, expectations are. If someone go, if a guy comes to see you, the sort of, in our age group, let's put it this way, and comes to see you with a sort of simple ankle sprain, and you're talking about the prostate and so on, does not make any sense, does it? But if you explain to the patient that the role of the practitioner is actually also to assess health and make sure that he's safe and there's no other stuff going on and so on, sure, when you ask questions about how's this and that, and yeah, sure, I understand why I'm answering the questions. But if I just sprain my ankle and you did not explain, and I think that, Cairo or an osteo does that stuff. I don't think I need to answer the question. I think, what is that coming from? So I think is a sort of explanation of the process. If people don't understand the process, it starts outside the clinical practice. Starts with the website, starts with the forms of communication, starts with the presence out in the wider world, right? It then sort of includes the people that work in your practice, who answers the phone, who kind of, welcomes the patient and so on. Because you could be the best practitioner in the world, but they come to see you and they just had a fight with the receptionist. They're not a good place, right? You can provide, you can think you can be the best guy in the world, but, it's not going to align anything. They are in a sort of super fight or flight or I kill you sort of state, and they're not going to sort of respond to the treatment. And getting the team together, I think this is, because each one of us will have a role to play in that team, I think.
What you're saying is so exquisitely important, but they don't teach this in school. And when I've realized over the years with interns, I often say that the examination starts before the exam.
Sure.
And the days when, in fact, I was just mentioning this yesterday to my new intern. Back in the day when people would handwrite and fill in their forms, I'm not a handwriting analyst, but depending on how thorough they were or how scant they were, that's how you may start to move into your consultation and history and exam. If they're, certain handwriting, if it's nice and big and flowing, usually they're very loving and compassionate. And they, I know it sounds odd, but even the first phone call to your front desk, I'll ask them, I go, what was the patient like? They were really friendly, or they were very short, curt, not very, they must be in pain, or, it was actually fascinating when you look into their history before you actually take their history. So you're very,
before you go, I'm what's this back in the day? I actually still do that because of those reasons. I still have everybody fill out their stuff. I still do all the handwriting stuff. I still do it. I don't do anything electronic because I think when you go electronic, you lose stuff.
Yeah.
And so I back in the day, I'm still in that day because the information is too valuable to throw it away and go electronic.
Sure. No, I agree with that. And I think, with that was much more of ultimately you writing, but you thinking, your clinical reasoning continues, you kind of, okay, all right, so I'm just going to ask you this question next.
Yeah.
And I think sometimes the typing kind of, you're there and a sort of, I know this from experience when I lived in the UK, a lot of patients complain about the family doctors, you call it the general practitioner, because, it goes to the guy sitting in front of a computer and the patient is sitting kind of, at a 90-degree angle and he's looking at the computer, doesn't never look at the patient. And the patient says, never looked at me, never palpated. No, I was there for 3 minutes, came in, got out. Oh, okay. Didn't watch anything, didn't realize that I was in pain or was fed up or whatever. I didn't see my body language.
Yep. Okay, and as a practitioner, and then when I go in as a patient and I have two nurses there and they're the ones writing the notes and they're the ones doing stuff and the doctor is talking about something else, I'm like, all right, where's this disconnect? It's just such a disconnect. I went back. We only did electronics for a little bit. I went back to everything's handwritten now. Everything is back to how it was when I first started. I got rid of all my electronics. I got rid of all my iPads. I got rid of all that. And people will say, "Oh, you're not high tech." And I go, "You're right. I actually want to make you better. I don't care about the high tech." And I went back to all that, and I got rid of the person in there, and I ask the questions now. And so it's interesting. On a fun note, I do want to ask you something because you listening, you talked about safety, you talked about Google, you talked about Dr. Google, Dr. ChatGPT, and millions of people look up sciatica, look up low back pain, and they already come in with a preconceived idea of what's wrong with them, right? Yeah. But most practitioners chase the pain, and And in your thought process, our brain has already made predictions what's wrong with us.
Mhm.
Where do you see that brain being wrong? And how do you see where the brain is getting it wrong? And how do you make this prediction and change this prediction into a different thought process when they walk into your door?
Well, I would go beyond just the brain, but think about the whole, the whole nervous system, because we can think about also the whole interoceptive system, because a lot of things are, before they go up to to the black box, they're kind of processed that in the periphery, in the viscera, and so on, and start sending the messages that anticipate the consequences of actions, and some kind, a lot of times they already start a cascade of events that could be protection, or could be, oh gosh, this is great, or whatever. um, and of course, what they bring, all the information they have been consuming, out there, quite a, some of it with some good validity, others very questionable, because it's, we know, if you go to Google, it used to be the worst case scenario. If you put back pain, you would be like, the differential diagnosis started with cancer to kind of probably going to die tomorrow anyway.
Right.
And so and people, humans tend, they're pretty good at sort of avoiding uncertainty, and they tend to catastrophize very easily, right? So if you kind of tell someone, oh yeah, it could be that, and your friends and a friend of a friend and so on all had that stuff, and really had the worst kind of case scenario, you tend to sort of think that that's probably what's happening with you. So it's normal that, in that in that context of uncertainty, that people tend to sort of get stuck in something that is protective. And I think, with this thing about predictions, and there's some complex kind of stuff that we talk about in our work, like the free energy principles and so on. But basically, if we're thinking from simple terms into thinking that at all times organisms tend to prevent entropy, right? And entropy is disorder. So we prevent entropy, and we tend to prevent entropy by very much limiting ourselves to a number of states that prevent that entropy. Right? So if this is bad for me, I avoid that stuff. This is something that I don't need to think about consciously. My system does it. Okay, so if I had an experience with something that the experience wasn't very, very good, next time I'm I have the same experience, I will get stuck in that, even though I anticipate what happened last time, and kind of, oh, don't move. So I think that is just a normal thing, and this can happen with pain, of course. So if we're thinking, last time I kind of had a long car journey, and I kind of got out, and I went on holiday, and kind of did let's say a 1,000 kilometer journey. Got to the end, I unloaded my car to the hotel. I got stuck, and my holidays were horrible because I had terrible back pain. Next time, I'm kind of think about driving, do a long car journey, probably my system already predicts that it's probably not going to be very good for me anyway. Okay, so the likelihood of me potentially develop back pain when I sit for long periods of time, it's probably going to be higher than would normally be for another person. It's kind of just an example. The same way, if you're thinking about, we mentioned before, back pain and bending forward, which tends to be one of the things people are quite scared about. Why? Because they see the picture of the disc, and you bend forward and the disc bulges, and you're going to touch the nerve root and all that stuff. So someone with a history of chronic low back pain, if you tell your patient in front of you, okay, I'm just going to assess you, let's do a few movements, would you bend forward, touch your toes? What you observe, in a lot of times, you observe them either moving really slowly, or going to extension, locking up the back, and then kind of try to go down. Okay, I said, no, it's not like that. It's just kind of, what you mean? You're telling me to go that. So the system knows that that is equal to danger, and if I'm preventing disorder, entropy, sure, I prevent that. I'm kind of, the system is not stupid, and with that anticipation of that, the system could even create so much tension that actually what happens, you start moving forward and you put so much tension that actually feels uncomfortable, is a signal that is enough to sort of, validates my model, and you are stuck in that. Okay, so this is in a nutshell, fear avoidance expressed through this prediction thing. Okay, and you observe this in with your patients. For example, in physiotherapy, the work of people like Peter Sullivan in Australia with cognitive functional therapy, they talk a lot about this stuff, and they even ask the patients, they do some exercises, some experiments with the patients for that, which one of them is, okay, imagine you want to move forward, and this is your fist. Okay, so make a fist and try to bend. And how does that feel? I think it feels horrible, right? Because I can't, I'm tightening up at the same time I'm kind of trying to move. Now try to move freely, relax completely, and try to bend forward. And the hand goes, and the sensations in the body say, wow, that's different. And that's a lot of times what happens with patients that tighten up everything, either because people told them contract the core before you bend or whatever, and they tighten up everything because they know that they anticipate the outcome is pain, and they lock themselves up. Okay, so in a sense, the difference here between what is the prior, the experience, and the actual experience now was the prior dominated over the experience. I already anticipated bending forward was going to be bad. I started bending forward. I got a little bit of a twinge. Ouch, lock, don't move. And they tell you, yeah, that hurts a lot. So we didn't move that much, did you? No, that hurts a lot. Okay. So how do you deconstruct that? Or how do you change that? So one way is to, of course, surprise the system, right? It's, of course, very easy to say, but a lot of times quite hard to do, right? So if you somehow violate their expectations by introducing something that's actually created a sensation that was one of they were not expecting. Let's continue with the back pain. Now let's imagine, for example, let's imagine they are kind of not sure, they're acute back pain, or sort of the back is very stuck, if you want to put it that way, and you decide, okay, I'm actually going to do spinal manipulation on the lumbar spine, but I do something very minimal, leverage, not a sort of huge levers, just something minimal that ultimately what I want to achieve is a bit of a shock to the system. Okay, so that sort of thrust that you get that sort of almost rebound, and suddenly clicked or didn't click, but kind of suddenly the muscles switched off, kind of, wow, there is that period of, oh, and then you imagine, okay, let's see, let's have a look, let's see how it feels. And the patient may tell you, I actually feel it's painful but feels better, right? And then they sort of, okay, well, now we'll leave it like that. Today we're going to observe how things progress and so on. And they start moving, they sort of going to start getting dressed. And they say, actually, I managed to put my shoes on, right? So from this perspective, what you have introduced, you introduced something violated the expectation that whatever movement was going to be painful. And with that surprise, because you surprised the system, you introduced something that provided you with an opportunity for resetting the whole thing, because ultimately they're the ones doing the reset, right? They're the ones that's through the movement. So I say, actually, I feel okay. Actually, it's a little bit better. And they go home and say, Yeah, it still hurts, but I can walk. Yeah.
Yes.
Versus the other guy that, you did all your testing and he finished and say, okay, still hurts. And yeah, and they continue like this. What basically you want, okay, then you can play with advice and you can be your psychologist by sort of reassuring them that actually, what happened is a protective mechanism, is there's a sort of a non-specific back pain, there's a twinge there, there's a muscle spasm, and the muscle spasm is there in the business of protecting. And once this starts getting away, the system knows that it does not need to be fire all the time to protect, because it's no longer an issue to protect. And I think, with this predictive model, of course, we have a system, either the nervous system, but arguably the neuroimmune system, working together. They are in the business of protection, and they protect, right? So of course, if you have, if you're fighting a virus or a bacterial infection or something, yeah, you expect the system to be pretty efficient at sending the troops to the right places to fight that. Okay, the problem then is when the problem is no longer there, but the system continues protecting, and you are in the protective mode all the time, which is what you tend to find at times with chronic back pain and so on, which is there's no longer tissue damage, everything is fine, the x-rays, the MRI show everything is fine. Why is the person still stuck? I think that's where the kind of being a little bit more creative with the approach, in my opinion, can give us an opportunity, a window of opportunity to sort of change, also using the body, because we haven't left the body alone.
It's fascinating. Not only what you're describing is so impactful, and that practitioners should make efforts at doing this more often, but it took a course in mild traumatic brain injury years ago, and it was I was the only they're all functional neurologists that were chiropractors that were studying this level of nervous system. And one of the comments, or one of the teacher showed us, was something about phantom limb pain. For those listeners and viewers that don't know what phantom limb pain, that is the extreme amount of pain and discomfort that someone has after they've had an arm or leg amputated, or they've lost it, and maybe in the military or an accident of some sort. And one of the solutions that they used, one of the treatments, was so fascinating. It would be to take a portable mirror, like a wall mirror, or even like if your closet is mirrored, your closet door, you could use your closet door and bring the mirror so you only see the side where you have the limb is still intact. So you don't see the one that's amputated or lost. And you do movements and exercise, and you actually create, it looks like you have a isomer, like a perfect image of the opposite limb in the mirror. So you're tricking your brain into believing that you have the limb, and it actually creates a cessation of the pain and discomfort that you were having if you practice this often. So what you're saying, that's like the epitome of what you're describing here, and how you change the thought or the brain.
Yeah. And ultimately the phantom limb pain is again on that business of protection. Yeah. So, the brain still has a representation of that limb, because, that doesn't disappear straight away, can, through neuroplasticity can remap and become shorter and so on. But for a while, it's still there. There's still a part of, the representation. So there's still a protection. And of course, you can trick the brain, because, by using, other senses, and this is the creating that, which is, for those of you that may have seen the rubber hand illusion, it works in exactly the same way. You trick the brain because, the vision takes over, for example, touch and proprioception, and you think that happens. But with that, with the mirror, actually, one suggestion for some of the listeners that we want to try is, again, with your chronic back pain individual, because this actually can work with mirrors quite nicely. If you've got two mirrors, one in front of a patient and one behind the patient, and imagine the patient has got problems in side bending to the right, if you ask the patient to side bend to the left whilst looking at the mirror in front of them, which they see their back, their brain sees them side bending to the right. So this is the thing, you can sort of remap, you can sort of change things by playing with the senses, and this is about tricking the brain. Yes, it is. And touch plays a role there, but I think sometimes we have to be clever and introduce other things in the practice where we sort of play with the nice plasticity of systems, and the thing is that the interaction at the end of the day. And as a kind of, yesterday I was chatting with a colleague that actually happens to work in a college of chiropractic in the UK, and we were talking about, because we're working together in the research, that what we should be talking about here that is quite important is the whole therapeutic encounter. It's not just a technique, it's not just what I do, but it's the encounter itself that it's got so much, communication. Sometimes there's no much, there's not much talk, there are patients sometimes, you don't talk that much, right? And you kind of do your stuff and they get better. And so, how do you feel? And so on. I had that experience when I lived and worked in Saudi Arabia, and for a while I did not have an interpreter. My Arabic is pretty bad. And in those cases, I kind of, survived with the basic communication, but, things that were very much through language, through, body language, through the hands-on care, and, at the end, asking someone to translate and so on. So it can be done as well. So it's not just, I need to talk, but it's create that, what I call in some of our papers, the therapeutic ecological niche, where you've got, within that niche, two people, or sometimes three or more, if you're treating, family, if you think pediatrics or geriatric care sometimes, or, husband, wife, or whatever, and then you have to communicate also with the other one, because, that's how you emphasize the importance of something else. But, within that niche, that communication, that is leading to changes. And I don't think, we need to be sometimes too precious about, is the technique is doing the trick. And, if I don't do the technique, I lose my identity as a practitioner. No, patients come to see a chiro because they like chiropractic, go to see an osteopath because they prefer that. Okay, it's not the technique itself, in my opinion, is the package, is the approach. And maybe some guys are kind of straightforward and get to the point, and other guys like talking a lot. Yeah, because we end up attracting the patients we kind of feel comfortable with, and they feel comfortable with us. Yeah. And that's fine. It's quite pluralistic here. It sort of doesn't have to be, black or white kind of thing. There's a lot of shades of gray in clinical practice most of the times, right? So,
yep.
So, Dr. Esteves, we're nearing the end of the show, but we have a fun part that, the whole thing is fun, but there's what we call rapid fire questions. There are five questions that I ask you. Yeah, 4 or 5 questions that require a quick and brief answer. And that's how we end our show. Some of it has nothing to do with what we've talked about. Some of it's all, personal and open to the public. If you're ready, I'll ask you the first of 5 questions. You ready?
That's fine.
Okay.
Yeah, sure.
Name one narrative reframe for maybe like a desk worker, something that is good for anyone who has a desk job.
Anything that's good for a desk job.
Which is probably everybody, most people on the planet right now.
That's a tough one. Set up some, actually use facilities of, a smartwatch, for example, to remind you to get up.
Very
often.
good.
So move.
Good. It's something that they would tell themselves, like your spine is adaptable, it's not fragile, things like that they would could repeat, right?
Yep.
Question number 2. What is one environmental tweak, something that, an hourly, like you had mentioned, that you feel everyone should do?
Get up and move. Yeah, have the excuse of going to the toilet, for example, but get up and get out and get up and move. I think that's the fundamental thing. Yeah,
very good. Or get up and grab something to eat in the refrigerator. That's
absolutely.
Question number 3. Build us a kind of a nervous system mixtape, or one song that would boost vagal tone, or one that would help the brain up, that would update these predictions during movement, and something for maybe a post-season integration. Is there a music or anything that you would suggest?
Actually, I mentioned my experience in Saudi Arabia when I didn't have interpreted. I used a lot of classic music, and particularly opera, and there was a good way of sort of really tuning into the autonomics, into the parasympathetic. Absolutely.
Actually, that is gaining a lot more attention. There has been some research on the Mozart effect.
Yeah,
on the
exactly.
body. What is it? The 2 pianos in D minor, the sonata, that it seems to be where the research was done. It's fascinating. That'll be good for another conversation.
Mm-hmm.
So you once highlighted F1 world champion Lewis Hamilton for giving osteopathy a shout out. If you were on an F1 grid with 60 seconds before the lights out, what's your no table, no tools, pit stop routine to kind of downshift someone's arousal for maybe a driver or a weekend warrior before that big moment?
Just a quick upper cervical kind of gentle release.
Very nice. He's good at these rapid
better
fire.
than you are.
Right? Yeah. You're Portuguese.
Yes.
Shaped by UK academia. So now leading in Malta. What's one?
Well, now I moved to Portugal.
You moved back to okay.
Yeah, I moved to Portugal after 26 years. Yes.
What's one tiny daily micro habit that you've borrowed from each culture that improves body awareness or lowers stress?
Oh gosh. From the Middle East, a sort of more laid back approach, kind of not worrying too much and let things happen. Sometimes can be bad, but or frustrating, because particularly when you're in the UK based system, sort of very much more intensive, more intense, more things that have to be done. Kind of routines to. So one, the more laid back sort of, breathing. From Portugal, I think
Eating.
Eating can be. No, well, my routines are, for me, fundamental is exercise. So regular exercise on a daily basis. So that's the kind of what I got from, what I can still, what I still continue doing. So stay focused.
Always a golden approach. Exercise is probably one of the most solid forms of therapy there is. Well, Dr. Jorge Esteves, thank you so much for all your information. It's been fantastic. And all the way from Portugal, this has been a great show. Thank you.
Thank you for your invitation, and it was really nice chatting to you guys. Thank you.
You're great. Thank you.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.